and welcome to the third and final session of the 2020 Stanford China Economic Forum. COVID-19 has had a profound and lasting impact on all industries, but none more so than healthcare. From the very first moments of the pandemic, the world looked to the field of biomedicine, and I'm proud at how the field of biomedicine responded to the crisis that COVID-19 has imposed upon all of us. Clinicians have served on the front line of patient care. Researchers have worked around the clock to understand the disease and develop vaccines. Public health professionals have espoused preventative strategies. These are just some of the ways that we've worked together to confront the novel coronavirus that has caused so much death and illness and economic destruction. We've also seen unprecedented levels of collaboration that have accelerated vaccine development and also that have accelerated the ability of us to bring therapeutics and vaccines to the benefit of the world. I'm optimistic that these experiences will change the future of healthcare for the better. Yet 9 months into the pandemic, we see some countries faring better than others. As the case and death counts continue to rise and set records across the United States, many countries around the world, especially in East Asia, are faring much better. These varied outcomes show that we still have much to learn, and I'm delighted that we have some of the foremost experts with us today. Our discussion today will touch on what we've learned from COVID-19, also on vaccine development and distribution, and how medicine will evolve coming out of this pandemic. I think we can all agree that the new normal emerging from COVID-19 will be significantly different from the normal we knew before in healthcare and in all sectors. With that, I'd like to invite Dr. Grace Lee to introduce herself and to say a few words. Grace?
Thank you so much, Dr. Miner. Really appreciate the opportunity to share my experiences with you. It's been a long 9 months, and I am excited that we're starting to see the light at the end of the tunnel with regard to the coronavirus pandemic. It's really an amazing story about vaccine development and the ability to really compress the timeline. So many of you might have heard today that the FDA VRBPAC meeting has just concluded and that the FDA has just approved the use of the Pfizer-BioNTech vaccine under emergency use authorization for the US for those 16 years and older. And tomorrow, the Advisory Committee on Immunization Practices will meet to deliberate on the recommendations for use of the vaccine in the US population and key clinical considerations that impact a vaccination program. I just wanted to offer a couple of quick comments. I hope that's okay. One is that, in terms of vaccine development, many things have gone incredibly well. It's clear that the expedited timeline of vaccines is a huge asset, particularly given where we are in the pandemic today. And in addition, the investment in multiple vaccine products simultaneously was critical. So the biggest challenge now is that we have an incredibly high bar for incoming vaccines. So this is a great place to start. The second thing I just really wanted to say quickly was that the importance of equitable and efficient allocation of vaccines, and I'm happy to chat about that a little bit. And then the third thing I wanted to just mention is the importance of vaccine confidence and the need for timely and transparent communication. And we're in the midst of that now, so lots to do. Thank you.
Thank you very much, Grace. And now I'll invite Dr. Gabriel Leung to do the same thing. Gabriel?
Thank you, Lloyd. My name is Gabriel Leung. I'm an infectious disease epidemiologist. And my day job is actually Lloyd's counterpart at the University of Hong Kong. So I think that what I may be able to share with the audience today online is to really answer some of the questions that Lloyd posed at the very beginning, why some countries and populations seem to have borne a disproportionate burden compared to others. And on the flip side, why have some countries done relatively much better in terms of minimizing or mitigating this pandemic? And what may actually be the outlook for different parts of the world now that we're into the vaccine era?
Thank you very much, Gabriel. And now, Dr. Tony Mok. Tony?
Thank you, Lloyd. I'm Tony Mok. I'm actually the chair of the Department of Clinical Oncology at the Chinese University of Hong Kong, a friendly neighbor across the harbor from Gabriel. what I can share is actually how this virus may have impact on the direct cancer care on the day-to-day basis, in our routine hospital care of our patients. And in addition to that, I'm also on the board of director of AstraZeneca, and probably I can share a bit of inside story of how the vaccine was being developed.
Great, thank you, Tony. And our first question is for Gabriel. Much of East Asia, including Hong Kong, has fared relatively well during the COVID-19 pandemic. And Gabriel, will take you up on your offer to help us to understand why that is, what public health measures have contributed to the success in Hong Kong and other areas in East Asia, and what role did the SARS 2003 epidemic play in the preparedness in Hong Kong and other places in East Asia for SARS-CoV-2?
Right. Well, thank you, Lloyd. I think this phenomenon, which I sort of call East Asian exceptionalism, as far as the pandemic goes, really, I think it's some sort of sociological imprinting. By that, I mean, East Asia, if you actually look back over the past century, has been the origin, or at least the first place of detection of most of the directly transmissible respiratory pathogen outbreaks. So out of the 4 influenza pandemics we've had since 1918, 2 of them actually were first detected in our part of the world. The 57 and the 68 pandemic, they were known as either the Hong Kong flu or the Asian flu. Now, of course, we've moved on in terms of naming these pandemics, but that shows that we've had a lot of experience. If you also think about the first human bird flu outbreak, that was in 1997. That was first picked up in Hong Kong. If you think about SARS, of course, it also was first detected in our part of the world. MERS, even though the name itself suggests that it may have been first picked up in the Middle East, nevertheless, Seoul in South Korea had a very large nosocomial hospital-based cluster. So that's really been the history, and I think that has done 2 things. One, it has really asked our governments to make sure that we have been prepared, and particularly in the last decade or so. Whereas if you compare then the disinvestment from public health in much of the West, including in the UK and in the US, that perhaps has made preparedness in the public health infrastructure all that much more important. But on the other hand, if you think about populations which have actually been so affected over the last few decades from these outbreaks, you would have a much more adherent, much more compliant population to perhaps what may be very severe, very restrictive physical distancing measures and other non-pharmaceutical interventions. So I think those together have actually made East Asia, including, by the way, Australasia, much better prepared. And therefore, that's reflected in the incidence and the mortality numbers so far.
Thank you, Gabriel. Tony and Grace, adherence to masking and social distancing guidelines is significantly different between the United States and East Asia. From your perspectives, why is that the case? Tony, would you like to begin? Go ahead.
Sure. I want to echo Gabriel that it is a sociological phenomenon. It's a lot to do with the mentality of the population. In the West, they will ask, why do you wear a mask? In Asia, we'll ask, why do you not wear a mask? So in a sense is that there has to be a reason to wear a mask. You may be sick, something wrong with you, that's why you wear a mask. But here, we have already seen wearing a mask is part of our routine, especially in face of a pandemic. I can still remember one time that I left my car and then I forgot the mask in the car. I basically run back to the car to get a mask as if I was not wearing any clothes. I need the mask to put back on my face. So I think that is a common mentality shared by the population, and is actually already people adopt to it. And I will say that in Hong Kong, 98, 99% of people on the street will be wearing a mask.
Thank you. Yeah, no, it's so interesting. It's, in the US, I guess I have personally thought about masking as more of a scientific issue or a technical issue, some of the challenges around that. But it clearly is beyond that. And as you mentioned, I think the socioculturally, it makes a huge difference, sort of what the expectation is and what the acceptability is. And that really drives our ability to adhere to this. We often see this in the hospital setting where adherence to infection control practices is often challenging because maintaining high adherence to everything all the time can be difficult. But once it just becomes the norm and the expectation, it's far easier once you get over that hump to be able to enhance, be able to achieve high levels of adherence and high reliability in an organization. And I think we as a society have not been able to achieve that high reliability yet in the US. Our hope is that we will continue to get better at this, as it's going to still be needed and going to be critical for us to be able to end this pandemic, to continue to have good attention to masking and social distancing, in addition to hopefully the addition of vaccines in the coming months.
Thank you. Grace, another difference, I think, between East Asia and the United States is the nature of the public health infrastructure. And at one time, many, many years ago, the United States had a very robust public health infrastructure. We did eradicate polio, measles, and there were mass vaccination campaigns at the time those vaccines were developed that were needed to do that. And yet, in recent years, recent decades, that public health infrastructure, I think, has become much more attenuated, particularly compared to the robust public health infrastructure in East Asia. What do you think is going to need to be done in the United States to rebuild our public health infrastructure? And how do you think we're going to get the buy-in to be able to do that?
I am so glad you brought that up. What a great question. It's so interesting, and I'll actually speak about the experience with vaccines. So our country in the US, we have invested a tremendous amount in vaccine development, a tremendous amount, not only in vaccine development, but thinking about the supply chain. And I'm so grateful that we have done that, because we would not be where we are today without that needed investment. In contrast, as we're talking about being able to vaccinate the population, the delivery system is so crucial. And so much of that really depends on our public health infrastructure, in addition to partnerships with academic or health systems like ours. But we definitely need strong public health infrastructure and leadership. I would say we have extremely strong public health leadership, for example, in the state of California, in our county, and I'm really grateful, but they are doing it on limited to no resources. And in addition to building upon this pandemic and the challenges we have with masking and testing and quarantining, we're asking our public health colleagues to mount the most complex immunization initiative ever launched, and to do it in short order without necessarily sufficient funding or infrastructure to be able to do that. We often rely on sort of the goodness and the sort of incredible leadership expertise of folks in our public health infrastructure. And I'm going to point to you, Dean Miner, as one of the folks that leads our system to be able to get things done. But it is a challenging task. And I guess I would advocate for strong investment in the infrastructure that's needed, because we cannot conquer this pandemic if we cannot get vaccine into the arms of individuals. So developing the vaccines is a huge and important accomplishment. But if we're not able to get those vaccines into the arms of individuals, including public health campaigns to ensure that we enhance public confidence in vaccines, then we're not going to be able to end this pandemic as swiftly as we would like.
Thank you. Gabriel, you were on the front lines when SARS hit in 2003. Why has SARS-CoV-2 had so much of a broader impact?
I think it's all to do with the viral characteristics. So I think if I have to point to one thing, it's really in terms of the dynamics, the temporal dynamics of viral shedding. SARS-CoV-1 back in 2002, 2003 really didn't start shedding significantly until about 5 days after symptom onset. And then peak viral shedding was right after or at the time of the high fever that came about a week after first symptoms. So in other words, from a public health viewpoint, what you needed to do to isolate these highly infectious individuals was basically pick them up in the first few days of them having symptoms. And that is much easier than compared to SARS-CoV-2, which is COVID-19, where peak viral shedding is actually at the time of first symptoms. And in fact, according to our estimates, 30 to 40% of secondary transmission happens before you even show symptoms. And that's really the key difference and why we've seen huge outbreaks all over the world. I don't think any country has been spared. And I think that is really the main issue.
Thank you. Now a question for all of our panelists. COVID-19 has brought about unprecedented levels of global collaboration between pharmaceutical companies and academic medical centers, between large-scale enterprises and smaller enterprises. And I'm wondering for each of our panelists, why has this occurred? And then are you optimistic that it will continue after the pandemic? Tony, maybe we could start with you and then go to Grace and then Gabriel.
Thank you, Lloyd. I would just focus on clinical research. This is what I do, on my day-to-day job. With the COVID-19 coming in, actually, basically, in the first reaction is that most of the clinical trial has to be stopped because we do not want to get our patient to get infected or exposed to the risk. But then we certainly know that this is not going to be a short-term situation. So we have to divide in some novel way of protecting the patient, communication, as well as collection of data in a safe manner. So very rapidly, we're almost transforming a little bit of most like so-called a virtual clinical trial. And that actually eventually add on to the efficiency. And now I would just say that our clinical trial capacity is back to about 80–90% of the normal. So I think this may likely stay, and this may likely impact how we do research in the future. So that I think that's one positive point about it. And the second point is that there are different levels of collaboration that we do not tap into before. But because this is a high-risk situation, because of pandemic, I think there are certain level of collaboration that we have established in terms of the communication, in some method of trying to do stuff that was different from before. And I think that will continue to impact in a positive manner on how we do and conduct clinical trial.
Thank you. And it's a great question that you ask. It's interesting. I am normally the optimist in the group, and I usually would say, of course, this would allow us to sustain. I will say that I have seen amazing collaboration happen as a consequence of COVID-19. And I would say that that is the silver lining of this pandemic, is that things are possible that were just impossible not even 1 year ago. So I do believe in, that the positive impact of this pandemic has broken down silos that otherwise I think would be difficult to break down over time. But that said, I've also remember my experience with H1N1 in the US. So during H1N1, for example, I saw incredible collaboration across federal agencies as well as internationally on many aspects of vaccine delivery and vaccine safety. I'm also seeing that again now, but we sometimes forget in between. So sometimes we need a pandemic to remind us how much we can accomplish when we work together. So my hope, I guess I will remain optimistic, Dean Miner, in that, is that over time we will continue to at least retain those components of collaboration that are so critical for us for accelerating development and accelerating implementation going forward. But I think we sometimes need chronic reminders for why it's important to do. It's easy for us to fall back into our old ways.
Thank you. Gabriel?
I think that collaboration has been tremendous, especially in the epidemiological and the public health community, certainly at the very beginning and throughout. And I think in terms of collaboration at an international level, there's been absolute unprecedented facilitation, not least by what we're using now, these online platforms. And indeed, in our own hospitals, you see a tremendous advance in terms of telehealth, where you would have thought that in a place as densely packed as Hong Kong, you wouldn't really need to have this telehealth virtual consultation service. And so I'm very optimistic about the post-pandemic era with one caveat. So I'm an optimist, but one who worries a lot. And that is at the international level, but the geopolitics, the tectonic plates of geopolitics have been shifting rapidly. And I don't think that they've been shifting in the right direction. And so that is one big worry that I have. And I hope that with changes in, for example, the US administration in the next month, as well as other post-pandemic goodwill that we've accrued throughout the year and in the coming year, at least, we would be able to find a new, better equilibrium going forward.
Thank you. Grace, can you tell us about the Advisory Committee on Immunization Practices and your role on it?
Thank you. Yes, I neglected to mention that at the beginning. So I am a member of the U.S. Advisory Committee on Immunization Practices. It is a federal advisory committee that advises the director of the CDC on recommendations for use of vaccines in the U.S. civilian population. So we really review and recommend vaccines for infants, children, adolescents, and adults in the U.S. We have been meeting specifically, and I have been serving on the COVID vaccine work group, as well as the COVID-19 vaccine safety technical subgroup. And we have been meeting essentially weekly since March. We've had over 27 meetings. As I mentioned earlier, we have another meeting tomorrow to review the Pfizer-BioNTech vaccine. And we'll anticipate more meetings next week after the Moderna vaccine, once it is approved for use, if it is approved, I should say, if it is approved for use, pending the safety and efficacy data review by the FDA. So our job really is to support thinking about how do we use it in the population. The FDA supports regulatory decision-making about the balance of safety and effectiveness. The other thing I'll mention is that what's unique, I think, about the Advisory Committee on Immunization Practices is that we do typically consider an evidence to recommendations framework that incorporates key principles. I'm just going to highlight for COVID-19, it's really been about not only the science, but also ethics and implementation considerations, all of which have been critical for each of the COVID-19 vaccine candidates that are coming forward.
Great, thank you. Tony, as a member of the board of directors of AstraZeneca, can you tell us about the relationship between Oxford and AstraZeneca? And how has that relationship benefited the development of vaccine candidates?
Thank you. This vaccine was actually so-called designed and then planted by the Oxford University Jenner Institute by so-called the Oxford Vaccine Group. They actually had this platform for a quite little while now. They had actually tested originally on the Merck infection, but they never need to come into clinical practice. But then when the COVID-19 come into, it's the same platform and a very similar virus, so they can really transform that and develop this new vaccine very quickly. But however, being a university, it's clear that they need a partner for development, clinical trial, manufacturing, and supplying in the future. And so for that reason, they probably look for a partner in the pharmaceutical industry. And then in the UK, AstraZeneca is a natural partner, given that this is one of the largest pharmaceutical company in the country. So very quickly, then the meeting took on, and then we decided on the partnership. And one important aspect is that the science and the so-called making it available to the population is a huge barrier, given the fact that AstraZeneca was not a vaccine company. We're predominantly an oncology company with respiratory medicine. However, we're willing to take on this task because we think we need to provide this to the world, and hopefully this will make a positive impact. And one other important aspect in our agreement together with Oxford is the fact that during the pandemic, we will make it non-profit to provide this vaccine so that the world can benefit from it. So that we set up team, the management of the AstraZeneca together with the leadership in Oxford. They have a joint committee and they plan the whole thing together. A lot of hard work. And then we have to not just on the clinical research side, which we already engaged more than 40,000 people in the clinical study, and also that we have to have a huge manufacturing facility. Being one place is not enough. We have to really find multiple manufacturing facility around the world and follow the very strict protocol to assure the safety and also the efficacy of the vaccine. And now we are actually looking in production of total of about 2 to 3 billion, and then distribute to 160 countries around the world.
Thank you. Gabriel, what data has been made available from the Chinese vaccine trials, and how does this data help in preparing a response to the pandemic?
Well, one of the things that has been extremely interesting, but also frustrating about vaccines generally is that we've really been, perhaps because of the urgency and the haste of developing vaccines and running phase 1, 2, and 3 trials, we actually haven't seen the data from the phase 3 trials with 2 notable exceptions. One is the already peer-reviewed Lancet report of the Oxford AstraZeneca vaccine. And then there is the VBAC document that we have seen made public because of the Pfizer-BioNTech vaccine process that Lisa was talking about just now, that Grace was talking about just now. And I think that, with these 2 singular exceptions, everything else has either not reported yet or reported via press releases. And neither of which are really very useful in terms of scientific scrutiny. So the most recent, and in fact, the first report of phase 3 data from a Chinese vaccine, so one of 5 that are in phase 3 or have been in phase 3, is one reported actually by the UAE. And that was 86, 87% efficacy. But again, we await with all of these vaccines, whether it's Russian, Chinese, American, or European, detailed data so that we could try and parse out the details and the nuances. One thing that I would say is most, if not all, of these first generation vaccines are predicated on the primary outcome of reduction in symptomatic disease, not infection and therefore transmission. And so I think that the first generation vaccines are going to be extremely useful, but they will not make this go away. What they will do is, hopefully, that they will be safe, first and foremost, and they will prevent you from suffering severe consequences, including death. But what they won't do is to bring this pandemic to a definitive end. So I think that we have to be extremely cautious while being extremely hopeful and encouraged by these latest developments.
Thank you, Gabriel. Maybe on that topic, and this is a question for all the panelists, but perhaps, Gabriel, you could start because it's a follow-on to what you just described, and that is that the vaccine itself is not going to bring this pandemic to the end. So maybe the questions would be, first, when do you think we'll see widespread distribution of vaccines? And then what are the events that are going to need to occur and the steps need to be taken to really bring the pandemic to the end? And maybe if each of you could pull out your crystal ball and make sure it's completely clear, when do you think that will be? And what are the various stages we will go through in terms of getting to the end? Gabriel, if you could start maybe, and then Grace, and then Tony.
Sure, and I think that, we are already making tremendously great progress. What we will see over the next 3, 6, 9, 12 months is progressive availability. And, I'm almost ashamed to say, starting from the richest countries on earth, and then progressively moving to middle and low income countries, unfortunately, but that does seem to be the way that it's going to be rolled out, is what you will see are priority groups first receiving these vaccines. And as Grace said, they will mostly be medical workers, first responders, and frail older people. Those would obviously be the first ones to get it, but you're not going to get wide availability, even in the richest countries, for a while because of vaccine manufacturing capacity. The second thing that you should be looking out for is sub-licenses issued to regional manufacturing hubs so that they can then manufacture for that part of the world under license from the original developers of the vaccines. So that's also going to come online soon. And then what you will see is once you get sufficient coverage of not having people to suffer the most serious consequences, then you will be able to actually get back to a bit of more normality in society. But you're going to have to wait for the second and maybe even third generation vaccines in order to completely take away the infection and therefore the spread. And I think that that's going to take a year or two. So we're not going to be back to normal pre-COVID levels for at least 12 to 24 months anywhere in the world. And just remember that as COVID has already shown us in the last 12 months, we are only as safe as the least safe country on earth because of our interconnectedness. And so I think that, it's a very encouraging message, but we can't let our guard down just because something has been approved.
Thank you, Gabriel. Great.
I'm going to agree with Gabriel, interestingly, but I'm going to put an optimistic spin on it, even though I agree completely with his timeline, which is, I do think that the comment that you made specifically about how effective vaccines are against asymptomatic transmission is going to be an incredibly important issue. The durability of immunity will also be important for us to consider. There's also the question about vaccine confidence, and are we going to be able to vaccinate enough of the population at baseline? My hope is right now, I feel like I am anecdotally seeing a lot of demand for the vaccine. So I hope that carries through all the way through the multiple phases we anticipate ahead. But, we won't know until we get there. So I think, again, depending on vaccine acceptability, that'll be huge. The other component that I think, and this is where I think your timeline makes sense to me, is having a vaccine available for children. One of the things that we've talked a lot about is, how do we think about getting back to normal? And I will say for those of us who are parents, a lot of normal is getting your kids back into school and having schools effectively reopen. So I do think having focus on making sure we're able to get clinical trials done in young children. Of course, the vaccines now are bridging down or heading down towards age 12, but we're not getting to the younger child population. And we do know that even though they haven't been the prime source of necessarily transmission in this instance, I do think they're going to be a critical and important population to vaccinate. So while I agree with your timeline, I'm feeling very optimistic about it at this point. Maybe it's where we are in the pandemic that I'm thinking a year actually sounds pretty good. I do agree vaccine distribution is going to be a challenge. But again, on the plus side, I think that's why there was investment in multiple companies to be able to develop vaccines. Each of the vaccines has unique characteristics that lend itself to different benefits, both from an implementation standpoint as well as from an individual standpoint. So I really hope that we will continue to extend that. And I apologize, I really should also mention that it is really important for us to think globally and not just within the US. For me personally, I focus a lot of our attention on US decision making, but recognize that a lot of these decisions have impacts in many countries. And so making sure also, not only the recommendations, but also thinking about distributional issues is going to be incredibly important, because I agree with you, until we can tackle it everywhere, it's not going to end.
So I echo Grace and Gabriel on both. I mean, in a way of apart from the challenge of the science, the distribution, the geopolitics, I think there are two other issues that we have to watch out. First is actually the media. I think it affects our mentality a lot. In a way, as there are already existing of anti-vaccine group in all community. And all you need is that the media is to talk about the negative aspect of the vaccine. That may change that a lot of people who are sitting on the edge, whether vaccine or no vaccine. I think that is actually very important, that I think media has to be very much careful and responsible and not to try to put a negative image of the vaccine to the general population unless they really, really know the absolute truth. Like for example, AstraZeneca had one neurological incident and it blew really right out of proportion, although it's a routine thing when we do clinical trial to stop and just see what happened and have a committee to review it. It's a standard procedure, but they make it as if something major happened, something really bad happened, and that really puts some unnecessary scare on the population. So I think there's one aspect that media has to be very responsible in this issue. Second, I think we have not talked about money. It costs quite a bit of money for the vaccination, and there are different pricing of different vaccine. How do the government so-called be responsible for it? Should it be just the government, or should it be, partly of the population to be paying for it? So I think that we really have to look into the whole financing side of the vaccine as well, because it's really a very costful endeavor to vaccine the entire world.
Thank you. Grace, here in the United States, we've seen COVID-19 have radically different effects on different populations. Specifically, COVID-19 has really underscored the social, behavioral, and environmental determinants of health. It's a sad fact in our country that the zip code in which a person lives is more determinant of life expectancy than genetic code. How is the CDC accounting for these inequities and inequalities in health and healthcare in its development of a plan for distribution of the vaccines?
Thank you for the question. From an ACIP perspective and a national recommendations perspective, equity has been central to our decision making. And I would say that our phase 1A focused, as Gabriel mentioned, on healthcare personnel as well as long-term care facility residents in order to maintain healthcare capacity, as well as focus on the population where we've seen incredibly high mortality rates. So long-term care facility residents, 6% of the US population, but 40% of the mortality. So that's been really important for us to address early on. Amongst what used to be called phase 1B, we had essential workers, adults with high-risk medical conditions, and adults 65 and older. And each one of those groups is incredibly important in terms of being able to protect those groups. I think we're waiting to see what the individual characteristics of the vaccine look like, but our last open deliberation for ACIP really addressed this, that at that time, prior to the Pfizer vaccine being approved today, our deliberations were really centered around this issue of equity. So we've talked a lot about how to address it, and the thinking of the ACIP was that by focusing on the essential worker population, many of whom are, low-wage workers who have to come to work in order to be able to fulfill their job function, that they are critical to the functioning of society, and they are being put at risk, just like healthcare personnel are every day. And so how do we address that population? And so that is why essential workers has become so important in the discussions around early vaccination or early vaccine allocation. There will be more deliberations on this coming forward, but just wanted to emphasize the importance of that. But then you ask a really great question, which is then how do you distribute the vaccines? And it's been so interesting for me being able to have the privilege of sitting at the national level and being able to deliberate on these recommendations at a high level, and then work with our state and work with our county and then work with our health system and realize that the considerations for implementation are actually slightly different at each level. And it's actually a complex endeavor. So we thought we had it all worked out at the national level, but we recognize that when you got to the state level, once it's allocated to the state, how do you think about it? And I really commend the state of California because they have incorporated what's called a social vulnerability index into their decision-making about how to allocate vaccines. So really allocating by location to communities that are more socially vulnerable or hardest hit by COVID. And there's much overlap between those two. In addition, at the county level, they've had to think about how to allocate to facilities. And again, they've considered equity in their deliberations. One example being that they might really focus in on ensuring safety net hospitals receive allocation of vaccine, or rural areas, for example, again, dependent on the vaccine characteristics, because we know that they each have very different conditions in which they can be stored. And then finally, at a very local level for our healthcare system, how do we think about it? And we've had to then take that, move it away from the location-based approach and really move it towards an individual level approach. And part of that deliberation has really focused on equity in our healthcare workforce. So we'll just say that when people think about healthcare personnel, they tend to think of first responders and nurses and doctors, but we have food service workers, environmental services workers, front desk folks, all of whom are critical, and actually all of whom are exposed, not necessarily more so in the workplace, but across the workplace and the community. The cumulative exposure is substantial, and sometimes we're seeing the highest rate in the lower wage workers, even amongst healthcare personnel. So that being said, would say that it's really important for us to ensure that we're maintaining the capacity of our workforce, regardless of where their exposure is. Thank you.
Thank you, Grace. Tony, what are some of the significant challenges and potential solutions of a global distribution system for vaccines for COVID-19?
I think we really have to look at the different vaccine may have the different challenges, like the upcoming Pfizer vaccine, they had to be stored at -70 degrees. And on average, median cost of a -70 refrigerator will be ranging from US dollar $15,000 to $30,000. So you can imagine that not everybody will have a fridge at home or at their hot facility to be ready to keep this vaccine. So that is for storage. I think that we probably have to build a lot more refrigeration facility, if we want to have wide distribution. And certainly in some part of the world, that may not be possible, especially when they don't have a stable electricity supply. And actually in our hospital, we probably have to back up electricity just to make sure our fridge is working, but that is for research purpose. But therefore, I don't think it's going to be widely available in terms of a -70 degree refrigeration. And on the top of that, there is the challenge of the transportation and how many can you fly with the carbon dioxide, with the dry ice, in terms of the keeping the temperature being low. So I think that's one of it. And then for the other one is actually the shelf life. In a sense, is that way is that how the vaccines roll out and how long that the shelf life of the vaccine has to be really worked out quite meticulously so that to assure that the population can get the appropriate distribution. And last but not the least is that who's going to administer it. If we want to do it quickly, we probably may need a lot more manpower to do the vaccination because it has to be done manually for now. And then, so, if we're going to do it just, with a limited manpower, it's going to take a long time before we can actually vaccinate the so-called entire population. So I think all these have to work into, but I think all those so-called, potential solution is probably around the corner.
Okay, thank you. Now this is a final sort of question before we get to the questions that have been submitted by our viewers today, and thank you very much. We've received several questions and we'll try to get to as many as we can, but this final question for each of our panelists. The pandemic has certainly shaken the world. What lessons do you hope that we've learned from it, and how will we become stronger because of it? Maybe we could start with Gabriel and then Grace and then Tony.
One thing that has really struck me, and it still bothers me a lot, is the deep and grave inequity. For the last year, COVID-19 has already become the single gravest health-related inequity in the past century. And that's mostly by omission. That is what we have not done to protect those who are most at risk, the disadvantaged groups, those who are on the margins of society, people of color, so on and so forth. And also between countries as well. Now, going forward, what distresses me is that we have not learned those lessons and actioned on those lessons to redress these errors by omission so that we can actually commit to make sure the vaccines are allocated and distributed in a just and fair way. And that really is the biggest lesson that I think we've yet to learn, and that we must learn.
So I 100% agree with you, Gabriel. I am glad to get to know you on this panel. This is actually, this has hit home to me so hard, just in thinking about how much not only health disparities, but I will say for our kids, educational disparities that have been exacerbated by the pandemic. And so I would say the one takeaway I would love for this group to be able to tackle in the next 3 to 5 years is not only innovation, but innovation addressing equity, as Gabriel mentions. And I think the way it's really interesting for vaccines, I've always focused on how much disease can we prevent, you know, how much death can we prevent? But I think actually we should be asking the question, how much equity can we achieve with this vaccine? And actually that gets also back to Tony's point about accessibility, making sure that the vaccine, that there's sufficient innovation and investment in innovation to address health equity as an outcome in and of itself, making sure it's visible and that we remain accountable to it. I think if we can do that going forward, we can actually make huge strides in health and educational equity.
And in echo to Gabriel and Grace, I think one thing we have to learn in amidst all this is how do we put down our personal agenda in face of a pandemic? There are actually a lot of people taking the pandemic for their personal agenda or striving for their personal agenda through the pandemic. But I think the only way for us to survive and do well out of this pandemic is that everybody learn to put down their own agenda and try to find a simultaneous process that we can do something differently to face our common enemy, which is the virus. So it's not an easy thing to learn. You know, I mean, in a way, is that when you see someone doing it their way and then you want to do it something for yourself, but however, putting it down, you know, your own agenda, I think is one difficult task for the future.
Thank you. Grace, would you explain the different types of vaccines in terms of the material actually being delivered in the vaccine and the mechanism? And also, can you comment on the differences between 2-dose and 1-dose vaccines? And what's your view of the strategy for maximizing immunity on a broad scale?
Oh boy. Okay. I hope I have all the answers for you. I'll do my best, and I'll ask my colleagues to chime in. So in terms of thinking about the differences, at least in the US, the first two that have come to the forefront have been mRNA-based vaccines. There are 2 additional vaccines that are viral vector vaccines, adenoviral vector vaccines, and then the other 2 are, you know, protein-based vaccines. All of them inactivated, all using different platforms. The mRNA would be the newest platform that we've seen used. In terms of thinking about the differences between the vaccines, I think Tony mentioned some of them. I would say I was shocked at when I first heard that the Pfizer vaccine was going to have to be stored at -70, because this is, again, thinking about logistics and distribution and cold chain. That's just something very different than we had ever faced, even in the US. And thinking then about accessibility in countries that don't have the ability to maintain that cold chain all the way through, that actually makes it functionally inaccessible to certain countries and certain populations. And so I think that is a major challenge. But we are, you know, glad that there are vaccines coming forth that will be more stable at refrigeration temperature, and I think that is huge. I think the second will be, I think our hope is that all of them will be incredibly efficacious and will be durable in immunity. One of the other questions I often get is, are the safety profiles similar or different? We have only seen the phase 3 clinical trial data for one of the vaccines so far. And then, as Gabriel mentioned, a lot of press releases about the safety and the efficacy of these vaccines. And actually, to Tony's point, a lot of press about single events that actually maybe just part of what happens in life, and yet not placed in full context. And so I do think that we are going to learn a lot about vaccine safety in the coming weeks and months. In the trials so far, everything appears to be safe. And I would say, actually, these are some of the biggest vaccine trials we've seen come through for vaccines prior to approval. So in fact, we have more data pre-approval than we typically do for any other vaccine. So I think from that perspective, folks should feel really good that anything that's coming through at this point with trial sizes of 30 to 60,000 per vaccine candidate is really important. How to effectively use these vaccines to maximize the benefit. So we have certainly thought about this. One benefit to address is equity, as we mentioned, and we've talked about how it is more challenging for us to be able to get -70 storage into, for example, rural communities or to smaller clinics or to areas that may be less able to maintain those storage temperatures, and that might impact accessibility and the timing of accessibility. So that creates itself some inequity. Fortunately, there are some more vaccines coming forth fairly soon. I think the other thing we thought about is, will the efficacy differ by age or by chronic condition? And if it does, then we would obviously want to use vaccines that are more efficacious in, for example, older adults if they become available. So far, everything looks good. And then I think the third consideration will be really around again, back to implementation considerations. So the 1 dose versus 2 dose you mentioned, there may be populations that are at high risk for COVID, but that may be transient in nature and difficult to track down for a second dose. And for example, then a 1 dose vaccine would be ideal in that situation to ensure that we're maximizing the immunity of that population and using vaccines judiciously. But we could have a whole other hour on it, Dean Minor.
Thank you. That was a great overview. Gabriel, on a per capita basis, India and much of Africa have fared better than other parts of the world. To what do you attribute the relatively better performance of India and Africa?
I think those are two very different questions. I'm not at all certain that India as a subcontinent has actually really suffered less in terms of incidence or mortality. I think that what we really need to see for everywhere in the world, but particularly the places that this question has concerned, is really waiting for the seroprevalence or the serology studies to look at what has actually been the extent of infection by looking at antibodies. And then also to make sure that death registration has actually been complete and indeed has picked up and correctly coded COVID deaths as COVID deaths. So I'm not sure about what the numbers really look like for India. And I think that that story is going to continue playing out as more data comes through. Africa, I would agree from what I've seen and from some of the numbers. And I think a lot of that is to do with demographics, where actually you have a very, very young continent and population pyramids in most countries in Africa, particularly sub-Saharan Africa, that actually look like a pyramid. That is a very broad, wide base and a very pointy top, which is not the population pyramids that you see in OECD countries, or for that matter, in some places in East Asia, like even China, Japan, South Korea, rapidly aging or already aged. So I think that there are two different stories that we're seeing in the subcontinent and also in Africa.
Thank you. Tony, Grace described vaccine distribution in the United States. What is vaccine distribution in Hong Kong going to look like?
Hong Kong is relatively wealthy country, and government probably can afford vaccinating majority of the population. So likely is the fact that the Hong Kong government will purchase a vaccine directly from one of the company and then provide it free of charge, hopefully, to the majority of the population. So, and also Hong Kong is a small place. I think the distribution will not be a huge problem as we may be facing in other countries. I think that the challenge is going to be on so-called the less economically preferring country, and also the more remote area. I think that will be a much bigger challenge than a place like Hong Kong.
Thank you. This final question will be for all three of our panelists. When we face the next pandemic, how might we better utilize technology for contact tracing and for disease prevention? Gabriel, if we could start with you, and then Tony, and then Grace.
I think that technology is the least of our worries. We already have the technology. The biggest question and resolution we need to come to terms with as a society, and it would be contextually different in different parts of the world, is what kind of trade-off we're willing and should, for the sake of the common good and public health and preventing or mitigating the next big one, be willing to give up in terms of our own privacy and freedom of information. So I think that that really is the most difficult question. The technology is the easy bit. The technology is already there. It has already been deployed very effectively, for example, in mainland China. So it's not a matter of having the right tech, it's having the right tech that you would actually either ask people to voluntarily do, or to actually agree to government imposing certain restrictions such that you would be able to follow up using those kinds of data. So we've seen it not only in mainland China, we've seen it put in good use in South Korea, for example, and we've also seen it voluntarily rolled out in places like Singapore, but the uptake has not been as great as you might hope for. So I think that that's really the big question. It's a philosophical, and it's a governance, and it's also a social consent issue.
Thank you.
I think that from this pandemic, we have actually established ourselves a ready-to-make vaccine platform. I think previously it took years to develop a vaccine, but now we have done it in less than 6 months or 8 months. And partly it's because of mRNA technology. The other also is from the chimpanzee vaccine and the virus. Both have proven that we can actually adapt to the virus and then so-called learning the genetic code and then develop vaccine very quickly. And also we have established ourselves that we can have the manufacturing and the clinical trial in a really efficient manner. So I think if this next time we come around, I think this has to be a very important tool in fighting the future virus.
Thank you. And I'll just chime in that I'm going to expand the question a little bit to say that we have some work to do in our country. I mean, we are reporting in multiple ways to multiple agencies on multiple parallel sets of information. I actually feel like we could use a lot of alignment and sort of harmonization of some of the data systems we have in hand. My guess is things are much better and much more streamlined in Hong Kong than they are in the US, and for multiple reasons. I will say the other sort of aspect of just being able to leverage the data that we have in hand is enhancing the usability of data. So I think that, we've had a lot of innovative, surveys and apps and things developed, but it's really, again, getting broad acceptance, which I think goes into Gabriel's point, and I 100% agree, probably 99% of this relates to privacy concerns and whether or not we're willing to be able to get culturally to that point where we recognize that the importance of mitigating the spread of disease, perhaps in this instance, would be a critical component of what a public health system could do more easily if people were willing to engage in reporting that kind of data.
Well, thank you. Unfortunately, that's all the time we have for today's discussion. I'd like to thank Grace and Gabriel and Tony for sharing their insights. I'd also like to thank all of you who've joined us today. The pandemic has created so many challenges, but it's also shown what we can achieve when we work together. It's in that same spirit that makes the Stanford China Economic Forum so special. I'm delighted that we today had the opportunity to participate. Be safe, be well, take care of yourself, and take care of each other.